Thanks, Colin, Nnadi again for his participation in our teaching activities. I know Nnadi probably more than 17 years.
Yeah.
He completed his training from the Wessex rotation in UK, and he was awarded the FRCS Orth in 2006. And then he took his first fellowship in spine in Royal National Orthopedic Hospital. There where we met, and really we had a good friendship at that time. And we have a good day and bad days in that area. Anyhow, he managed to get another fellowship where we split. I got my consultant job, and then he did a locum in the Queen's Medical in Nottingham. You know, that's a big surgery center for the spinal pathology. And after that, he appointed as a consultant orthopedic spine surgeon at Oxford University. This is in 2008. Colin, he had a special interest in pediatric deformity and general spinal condition in children. He is ex-chair of research committee in PAS, British Orthopedic Spine Surgeon, and he's a chief investigator for the UK multi-center Magic Rod trial in early onset scoliosis. And he's also a chief investigator in the pan-European K-spine study of adolescent idiopathic scoliosis. Also, he published a lot of papers in a well-known journal, and he published his book on early onset scoliosis. I think we have a copy in our unit. Okay, Colin, without further ado delay, please, if you start your presentation.
Thank you. So can I share the screen now?
Paco, could you stop sharing?
Yep, stop share, pause share. Okay, done.
Okay.
I think you can share now, Dr. Colin.
Yeah. Can you see it? Can you see my screen? Sorry.
Still not.
Sorry, I'm just going to the beginning. Sorry.
Colin, we can see nice beach though.
Can you? So you can't see?
No, not yet, doctor.
Okay. Let me see. Can you see now?
Yes.
Yeah.
Okay.
Now clear. Yeah, just if you could please put it in presentation, that's great.
I'm just going to the beginning. Sorry.
No problem.
Yeah. So thank you for the introduction, and thank you for inviting me to your esteemed education program. So I currently work in Oxford as head of department, and I also have a practice at the Portland Hospital in London. So this is where I work. This is our elective hospital site, the Nuffield Orthopedic Centre, and this is the John Radcliffe, where we do our complex and emergency work. So I just thought before I speak to you about the magic rods themselves, I'll just do a little bit on early onset scoliosis so you understand the reasoning behind the magic rods. So early onset scoliosis is any scoliosis that occurs under the age of 10. And in terms of the classification, the early onsets, like the adolescent type of scoliosis, can be classified into the infantile, idiopathic, congenital, neuromuscular, syndromal, post-paralytic, tumor, trauma, and that can either present early under the age of 10 or later on in the adolescent years. So that means that sometimes when you see, say, for instance, a 13-year-old with a curve, that curve may have been around for a very long time. So in terms of the history taking, it's important to establish how long the curve has been present. Sorry? Sorry? Can you hear me?
Yes, yeah, clear, actually.
Okay, fine. So why do we treat early onset scoliosis is the question. So if you can just, the next 5 slides or so, if you just, bear those in mind, and it will answer that question. So the natural history of untreated scoliosis is what happens if you don't do anything. So in the early onset group, the graphs on the right represent expected death rates in the normal population versus those with early onset scoliosis who haven't been treated. So the bottom line here is the expected death rate in the general population, and you can see most people will live to about 60, 80. In the early onset group, that's the under 3 years in this case, you can see that after the age of 40, the mortality goes up quite sharply. And the same thing for the juvenile group. So the straight line there is the general population, and then this is the juvenile group. After the age of 40, the mortality rate goes up. However, in the adolescent group, the mortality rate or overall death rate is the same as the normal population. So in the early onset group or the under 10s, it is critical that you treat them aggressively to prevent early mortality and morbidity. So the next slide shows the development of the thorax. And this is a slide that my friend Alan Demeglio kindly gave to me. But what he describes here is that if you look at the thorax in a newborn child, it's only 6% of its expected adult volume. By the age of 5, it's only 30%, and by 10 years, it's 50%. So if you have a severe deformity developing from birth to 10 years of age, that child may only achieve 50% of the normal lung volume, which leads to long-term cardiorespiratory problems. And again, in terms of other growth parameters, the weight, thoracic volume, T1 to S1 height, sitting height in boys, sitting height in girls, at the age of 5, none of these parameters have been optimized. So it's very important that if you see a child with scoliosis at an early age, you have to treat it aggressively. Otherwise, they don't achieve their full growth potential. And then if you remember, and I'm sure many of you will know, that with those scoliosis cases that don't respond to non-operative measures, the only other solution is surgery. And historically, the different types of surgical options available were either distraction-based, such as the single or dual growing rod systems, the vector device, growth guidance, the Schiller, the Luque trolley, or compression-based with stables or screws and tethers. And the big thing about each of these is that they required repeated surgery. So these children had to be taken back to theatre several times. In fact, when I say several times, that's an underestimation, because if you, for instance, imagine that a child at the age of 6 is fitted with these, with one of these systems, by the time they're 12, they would have had 12 operations, because they have to go back at least 2 times a year if they're lucky. So this picture on the left shows the traditional growing rod system undergoing a distraction. There was no real science behind it. You just open the child and apply as much force as you could to distract the device. Whereas with the magnetic growing rods, there's an operation to insert the device, but then when it comes to the distractions, you do them in the outpatients department and no surgery is required. So this is the big shift in early onset scoliosis surgery, that you now have this device that allows you to optimize growth in children without having to perform surgery on a repeated basis. So in terms of background of this device, so it's a non-invasive lengthening. They're originally called the magic rods, They're now called, and most people or papers will refer to them as MCGR, and they were introduced to the UK in 2009. I first saw them in 2010. First reports were by Kenneth Chung in Hong Kong in 2012 in The Lancet. I performed the first two cases in Oxford in December 2011 on twins with a neuromuscular disorder. The system itself, you have sterile single-use surgically implanted rods and an external remote controller. On the whole, the magic rods have led to, well, a sea change is an understatement. They've revolutionized how we treat early onset scoliosis surgically. And this just shows, is an example of one of the earlier rods. So you have the actuator section there, which is this thickened bit here. This now comes in 7 and 9 millimeters diameter and can be either 70 or 90 millimeters long, depending on the age and size of your child. And then you have the shapeable rods, which is this portion, or this has actually been cut off. But this portion and this portion are the bits that you can contour to fit the spine. And they usually come in 4.5, 5.5, and 6.3 diameters. So this is just the rod length, the proximal rod to the actuator, and then the distal rod to the actuator, but that's all historical. So it's attached to the spine using standard hooks and screws. You can have a fully rigid construct, which is this, or you can have an alternative construct with freely swiveling joints to reduce the stress on the bone implant interface. Although this type of design is rarely used nowadays. So I don't think anybody, it was in use when it first came out, but it's not used anymore. So the remote controller, this is the latest remote controller. It's portable, it's handheld, it has two magnets inside, which lengthen the magic rod through the touch of a switch. The amount of distraction or retraction can be seen on the screen there. And if you have two rods, you can actually distract or shorten them independently. So this is just what you get in the external remote controller. You have these rare earth magnets that are polar opposites to the magnets within the rods. So when you apply the magnets in the external remote controller, because it's an opposite, it has opposite forces, it creates an axial force that allows you to distract the rod. So in terms of the distraction techniques, it's done in the outpatient setting. And historically, there are two main distraction techniques. So it's either the targeted distraction technique, which we developed in Oxford, or the maximum distraction technique, which is more commonly used. The targeted or tailgating distraction technique, as we call it, is based on the Demeglio growth charts, and you titrate the weight of the child to the amount of spinal growth expected, and that's what you apply. And you divide that over the year, and then on each visit you apply a fixed amount of distraction. So Ken Chung in Hong Kong was distracting them monthly, and then Hilali Nordin in Stanmore was doing them 6 monthly. But I'll talk about the distraction later on. So when you distract, the most commonly used method to assess the amount of distraction is with ultrasound. We in Oxford don't use the ultrasound technique. We use fluoroscopy simply because that allows us to not just to look at the distraction gap, but to also look at the whole construct. So for, to look for things like screw pull out, rod breakages, whereas the ultrasound technique doesn't allow that. So this is our fluoroscopy suite in Oxford. The child lies on the table here face down, and the distractions are performed with the child lying face down on the table, and then we get the images after the distraction. And like I said, it allows us to assess not only the rods, but the foundations and the curve as well, to see how well it's being controlled. And we published that a few years ago. So this is what the rods look like. Like I said to you, you have a 90mm rod and a 70mm rod. The 90mm rod allows up to about 5 centimeters of distraction, whereas the 70mm rod allows just about 3 centimeters of distraction. And it was really, these rods were designed because if the original design was just the 90mm, but then with the very small children, this was too big. So the company came up with a smaller rod that allows you to insert the device in smaller children. So you can use a single rod construct. I sometimes use a single rod construct for the very severe curves. You can use a dual rod construct where you have an offset rod and a standard rod, and you basically put them in opposite directions. Or you can have a dual rod construct with 2 standard rods where you put both rods facing in the same direction, but that's really down to the surgeon. So I'll go through the evolution or our experience with MAGIC in Oxford to just show you how it's developed. So I think the first sort of UK paper was in 2013 by Danawi et al. And Hilali Nordin. They looked at 34 children, mean age of 8 years, pre-op Cobb angle of 69, corrected to a mean of 47 degrees. So they came to the conclusion that it was a safe and effective device in treating progressive early onset scoliosis with repeat surgical lengthenings. The same group also looked at, in a much younger age group, looked at pulmonary function in children with early onset scoliosis. So it's a very small case series and a very young group, but they came up with a conclusion that early intervention is associated with significant improvement in postoperative pulmonary function test. And I don't think anybody really knows why that occurs, but one of the things that the parents always say is that their children are a lot more active, they eat better, they develop better after the insertion of the rods. So the criticism of this device was the cost. As you know, we're now in a very cost conscious healthcare environment, and one of the problems with getting widespread acceptance was the cost of the rods. So we performed a cost analysis back in 2014, comparing the magnetic growing rods to the traditional growing rods. And so I've just highlighted the important figures. So the cost of inserting a traditional growing rod was about £22,000. And this took into account the pre-op assessment, initial insertion, the lengthening, revisions, post-op care, complications, and then outpatient follow-up appointments. And the cost with the traditional system came up to just under £23,000 in the first year. By the 5th year, the total cost was about just under £53,000. Whereas with the MAGIC rods, the initial insertion cost was much higher at £33,000, but by year 5, cost savings was about just under £9,000. And NICE, which is the UK equivalent of the FDA, looked at these studies as well. They actually used our cost analysis and brought in a sensitivity analysis, and they actually realized a £12,000 savings per patient. So on that basis, in 2014, the system was given a NICE approval and adopted by NHS England as well as the private sector. And I think later on that year, it got clearance in the US as well. So we then published our first series, our early radiological results in 19 children. Initial Cobb angle, 62 degrees, and then post-op 43 degrees. The impressive thing was that the T1 to S1 lengths also improved from 280 millimeters initially to over 330 at final follow-up. So we again agreed with previous authors that the magnetic growth rods had the potential to reduce the need for multiple operations and were generally a safe device. These are some of the more detailed analysis, and most of the best results were in the primary cases. So you can see the mean Cobb angle pre-op was 66, and then post-op, so the mean Cobb angle, sorry, in the primary cases was 59 degrees pre-op, and then post-op was 37 degrees, which was statistically significant. In the revision group, the correction or the difference wasn't as marked. So you had 66 degrees pre-op versus 56 degrees post-op, which was not statistically significant. And the same differences were found for the T1 to S1 length, where you had 296 pre-op going up to almost 350 post-op. But then for the revision cases, you can see that the difference wasn't as marked. So this just shows the trunk growth in both the primary and revision cases. But despite the differences or improvements not being as marked in the revision cases, there was still improvement in the T1 to S1 height. So we then looked at the device in terms of the distraction achieved. So if you were dialing in, say, 5 millimeters of distraction, were you actually getting 5 millimeters of distraction inside the patient? And what we found, so we came up with what's called the true and intended ratio, true distraction versus intended distraction ratio. And what we found was that for every unit of distraction registered on the remote controller, you only got 33% of true distraction in the patient. So in other words, you were not getting the full distraction that you thought you were every time you lengthened the patient. But having said that, when we were looking at all their growth parameters, their radiological parameters, the Cobb angle correction was being maintained, the growth was being maintained, and therefore we took the view that this wasn't necessarily a bad thing, and that we didn't have to change our practice because the children were still achieving good results. So around the same time, because one of the complications with the traditional growing rods was the incidence of PJK. So we wanted to see whether this occurred in the magic rods, and to our disappointment, it did. But the magnitude of the PJK and the rate of progression were slower compared to the traditional growing rods. And we also found that the risk factors were being male, syndromic, hyperkyphotic, and of a younger age for the development of PJK. So we advise that in that patient group, you pay particular attention to their follow-up. And that should form part of your consent process. So the other big thing that started to come out of these, using these rods after the initial optimism was metallosis. So that's a picture on the left of one of my patients where the rods have been taken out. And this is basically staining of the tissues around the implant with wear debris. And this was first highlighted in 2016 by the Cardiff group. So this was an interesting paper, but the only downside was that they didn't give any details on the patient data, length of how many follow-ups they were getting, how many distractions they were getting. So it wasn't quite clear, but it highlighted a very, very important complication with the use of these rods. The other thing that started coming to light was the pin breakage. So the internal distraction mechanism, as you can see, the pin there, which forms part of the internal distraction mechanism to lengthen the rods, was breaking. So there were a few cases coming back with broken pins, which meant that the rods were no longer lengthening, which meant that they were also pistoning. And it was felt that this pistoning led to generation of excessive wear debris, which made the metallosis worse. So the company have since modified this design, and the incidence of pin breakage is a lot less. And then an international group of us, surgeons from different countries around the world, got together in 2017 to look at our results and to see whether these new rods did actually have the desired impact on treating early onset scoliosis. So we looked at our complication rate, but more interestingly, we looked at our unplanned reoperations using the rods. And to our surprise and disappointment, nearly 50% of the cases underwent unplanned returns to theatre. And the average time to return to theatre was just under 2 years. The other finding to come out of this study was that those cases that were subject to more frequent distractions were more likely to fail than those that were being distracted 3 to 6 monthly. So it was something like 70 to 30% ratio. And then there was a group of surgeons in the UK, all of whom are good friends of mine, who came out with a very sensible article on the use of the rods. And I think constructive criticism is always a good thing. And they basically said, yes, the system may be good, but it's still in its infancy. It's still a new innovation. And like all new technology, especially when deployed in pediatric populations, can be prone to failure. So they suggested, that care be taken when applying this device in the pediatric population, having the right surgeon, having the right patient, and then making sure that they're followed up in an appropriate manner was important. So all this while, we had been carrying out an NIHR, so that's the National Institute for Healthcare Research study, over 2 years, observing the progress of the system, and we published it 2 years ago. So our findings, I'll just summarize what we found. So it was a small series, there were 10 patients. It was an observational study with no comparator group, but we had no device failures at 2 years. It's safe to use. It controls the spinal deformity and did allow growth, but the complication rates were still high. There were no infections and there were no neurological complications. And all this study, what this study emphasized was that if you select your patients carefully and you have the appropriate expertise, then you will get good results. So like I said, there were no device failures. The complications were around general complications and not specific to the device itself. And more importantly, there were no infections either. We then, the same year, we then published a bigger study of 31 children. So this is an entirely separate cohort of patients with a longer follow-up. And again, observational cohorts, 31 children, 15 males and 16 females, mean age 7.7 years, and the mean follow-up was for just about four years. So, and all the cases in Oxford are distracted using the tailgating technique, as I described previously, and I run the clinic. So the post-op distraction clinics are standardized because it's the same person using the same technique for all the patients. So in summary, what we found was that both primary and conversion application provides significant and sustained deformity correction with improved growth and functional outcomes. The patients with dual rod constructs, idiopathic etiology, who have primary surgery over the age of 7 are more likely to have better results. The rate of complications, so the overall complication rate in our series was 67%, including those warranting unplanned returns to theatre. The device-specific complications was approximately 20%. Most complications occur around 3 years. So we have now taken to advising our patients to either have an exchange or convert to a definitive fusion if they're at the appropriate age. We then, I suppose one of the things about the distracting or distraction technique is that there are 3 main methods. So there's my method from Oxford, there's Hilali Nordin's method, and then Kenneth Chung. And I think we were the first to actually try and validate our distraction method to see whether it works. So what we did was a retrospective analysis of European children treated with the magic rods and using the tailgating technique, and analyzed the post-op and clinical and radiographic outcomes, including sitting height, standing height, and the Cobb angle, and the T1 to T12 and T1 to S1 height. We also compared the post-op sitting standing height ratio every 6 months to those reported for normal age and sex matched European children. And what we found was that the tailgating technique mirrored the normative sitting standing height ratios for expected spinal growth. The mean difference between the reference values for the sitting standing height ratio and our results was very small and not statistically significant. So the technique does work, and I think it's the only one of the 3 that has been validated. So the other paper that we published was looking at the law of diminishing returns in the magic growing rods. Because I'm sure all of you will know, this is a common phenomenon in the traditional growing rods. So we wanted to see whether it happens in the magic growing rods. And so it does happen, but rather than a rapid initial decline like you get with the traditional growing rods, this gives you a gradual linear decline. And we also found that with the older the child, the heavier they were, the distraction ratios, particularly on the concave side, were reduced over time. We then did a systematic review of the complications associated with the magnetic growth rods. We reviewed 253 papers and then whittled that down to 15 included in the review because the others did not meet our inclusion criteria. And our take-home message from this was that the rods do improve the deformity and maintain spinal growth. In terms of the non-medical complication rates, it's about 45%, and there's a 33% unplanned revision rate. So the most common complications were ankle pull-out, implant failure, and rod breakage. More recently, and I don't know if you've heard about this, the company has come out with its latest design called the Magic X, but it's had to withdraw this design because in addition to the previous pin fracture, it's now experiencing an end cap failure. So the Magic X design has been removed from production while they sort out the technical problems. But in the meantime, because of the, so like I said, this is with the Magic X, the implant issue is the risk of separation of the end cap from the housing tube after implantation. With previous designs, it's the internal locking pin that was the problem, as well as evidence of failure of the ring seal. So both of these can lead to generation of titanium wear and corrosion debris, as well as discoloration of tissues, but there is no evidence of long-term effect, of any toxicity in these children. In terms of, because of COVID, I understand that's not so much a big deal in Qatar as it is around here. But there have been delays in doing clinics, but the advice is generally not to leave it for more than 6 months before you do a lengthening, and then also to make sure that the patients are being followed up during this period. And our latest publication is just on how to try and make the distraction process more accurate. Because like I said to you, one of the difficulties with distraction is that you don't always get the same amount of distraction inside the patient as you do in the remote device. So we came up with a technique that more accurately localizes the magnets within the rod. And it was felt that if you can actually improve the localization of the magnets, then you're likely to improve the accuracy of your distraction. So we came up with what we call the Oxford Magnetic Counter App Technique, or TOMCAT for short. And what we did was to compare 3 distraction mechanisms. First is using the wand. The second was the disc. The wand and the disc were the first, actually the disc was the precursor of the wand, and then the wand followed later. But then we've used a metal detector app to localize where the magnets are. And these are our results. So the smartphone app, when compared to the wand and the disc, in terms of localization error, fared a lot better when we looked at all our models. So we had a model patient, and we created an overweight model, and then an average adiposity model. So when we looked at all of them, the smartphone app performed better than both the wand and the disc. When we compared the wand to the disc, there wasn't, I think the wand did a bit better. But then when we had the overweight patient, because that was the issue that made me develop this technique, because what I was finding was that in the overweight children, it was more difficult to localize the actuator, and therefore you were never really sure that you were placing your remote control in the right place. So in the overweight child, again, the smartphone app was a lot better at localizing where the magnets were. So this is now a technique that we use for our distraction clinics in Oxford. So I'll just summarize. So in summarize, the magnetic growing rods have revolutionized the treatment of early onset scoliosis. In my opinion, and I think in a lot of my colleagues in America, particularly Baruz Abania, who has led the way on using this, on the use of this device. It is the device of its generation. Your patient selection, like everything in surgery, is key. You've got to select the right patient to get the best results. Despite its impact on surgical management of early onset scoliosis, it hasn't solved the problem. So all the usual problems, like I said, PJK, law of diminishing returns, rod breakages, wound infections, failure of the device, failure to control the curve, all those problems are still there. But the main progress, if you like, is the fact that the number of surgical episodes in such a young patient group is considerably less. And that's just reiterating what I said about the problems of repetitive general anesthetic. So thank you. So questions, please.
Thank you very much, Dr. Nnadi. Really great presentation and great information for all of us. So we have one question from Dr. Firas. He's asking about how you control or take care of the sagittal balance while you are doing distractions for the.
Oh, why are you doing this? Well, I think the important thing is that when you put the rods in initially, you have to contour it. Mm-hmm. You have to, so where you place it, you have to place it so you have to place the actuator over the thoracolumbar junction because it's flat. Mm-hmm. It's flat, so that's where you need to place it, and then you make sure that you contour the proximal rod and the distal rod. So when you're putting it in, you don't force it in. You know, because I've said this at many meetings, because you see people trying to cantilever it in. You don't force it in. You almost have to drop it in and secure it. And so when you're lengthening, I think PJK is unavoidable. That will happen. But I think the rate of development of PJK is slower. And then what I started doing recently is also using sublaminar bands at the top of the construct. Mm-hmm. So I'll put the 4 screws and then put sublaminar bands on either side to try and, pull the spine back. But I think in the long term, they all get PJK.
Thank you, Dr. Abdul Jabbar. If you don't mind, can I just add something?
Yes, please.
Yes. Thank you, Doctor, for this very informative lecture, and also it's almost always evidence-based lecture. Thank you. I just want to ask about, I mean, not only PJK in the sagittal balance, but also other things about hypokyphosis or even lordosis sometimes. Are there any tips to do, and not only in magnetic rod, your experience in any elongation rods? Thank you.
Yeah, well, I think your pre-op preparation is important. So preoperative planning. So you need to identify. So those patients who are hyperkyphotic from the beginning, you're going to have problems. So it may be that the magic rods are not suitable, that you may need a different type of device. So, it's your pre-op planning and awareness of the sagittal parameters. In children, it's difficult because their sagittal parameters are changing, are evolving with growth. So it's difficult to predict, but certainly your preoperative planning, preoperative presence of kyphosis, preoperative presence of PJK. In some of the syndromic children, they may already have a pre-existing flat back deformity. So you need to be aware of these, and therefore, down to minutiae, like even the way you position the patient on the table, you make sure you position them, because sometimes if you have, say, a Montreal mattress that is too big, then the abdomen tends to sink into the mattress. And if you're not aware of that, you may fix the child with a hyperlordotic profile. Mm-hmm. Or sometimes if you have pillows under the tummy that cause flexion of the lumbar spine, you may fix the child, with a flat back deformity. So it's all these things, and making sure, like I said, the most important thing is that when you put the rods in, you're almost dropping them in. And that's why if my plan is to put a 2-rod construct in, and when I put on the convex side, I put the rod on, and I think I'm going to have to force it, then I just put a rod in the concavity, and I'll put a 5.5 diameter rod in the concavity, and then 4 screws at the bottom, 4 screws at the top, with short screws on the short rods on the contralateral side, and cross connectors to increase the strength of the single rod construct, and that usually works.
Okay.
Thank you.
Is there any other questions? I think Dr. Basim asked about is there any contraindication for using the magnetic?
Yes, there are. So it's again, it's even, there are some children that you see, or even the family environments, social issues where the parents are not going to come back for the post-operative lengthening. So there's no point using the magic rods. I personally don't like using them in the neuromuscular children, simply because I used to, because I thought, oh, well, it would be less surgery. But then the problem with the neuromuscular children is that any trip to the hospital it's a big deal for the family, just getting the wheelchair, those of them who are on parenteral nutrition, getting everything into the hospital. It's traumatic for them. So for the neuromuscular children now, I tend to use either the Schiller growing system or the Luque trolley, which means they have the operation and that's it. They only come back for an X-ray or whatever. So if you have a hyperkyphotic child, if you have a child who is very small or very thin, so there'll be some children, because if you put the rods in a child with a small subcutaneous fats ratio, the rods will be prominent and may cut through the skin. If you have a child with previous infection, if you've have a child, like I said, like I had one boy who just wouldn't, he'd come to the hospital, but he wouldn't tolerate the lengthening. He didn't like anything touching his back. So there were several times when I had to just say to the mother, just take him home and bring him back, So those are the sort of cases that you don't use the rods in.
Okay. Can I ask a question, Abdul Jabbar?
Yes, please, Dr. Said.
Colin, great talk. Thank you very much.
You're welcome.
Your protocol for lengthening in outpatient setting, do the children need analgesic, sedation, or is it painful?
No. They don't need anything. In fact, it's 5 minutes. So in my clinics, I have an assistant, I have a radiographer, and then a nurse. So the nurse brings the child in, undresses them, they're put on the table, and then usually, if it's a first time, I usually ask the parents to go online and look at the video, or show the video to the child in the clinic before we start. I give them the remote controller to play around with. and then we do the lengthening. For those children who don't like lying down, then I ask them to sit on their parents' laps, and then, you know, with their back facing me and their arms around the parent's neck, and then the parent lifts them up under their armpits, and then I do the lengthening that way. But they don't need any analgesia or sedation.
So other question, is there like a specific age you usually change the magic rod or the regular rod for definitive fusion?
Yeah, well, it's the usual age of 12 or 13. So like I said in my talk, when we looked at our series, most of the failures were occurring at about 3 years. So if I have a 9-year-old child that I put the rods in, when they're about 12, I say to the family, look, it's time to think about a definitive fusion. The problem that we're seeing now is that most parents will say, no, I want them to continue growing. If you fuse them, they won't grow anymore. So I want them to continue growing. So I've actually got patients who are 14, 15, that I'm waiting for the rods to fail. So what I say to the family is, okay, well, the rods will fail. And when they fail, I'm not putting in new rods. I will fuse them. Mm-hmm. If the child is 6, then when they're 9 or 10, I mean, it's very difficult because you have some children. For instance, I have one patient, he's had his rods in for 6 years, 7 years, and they've just been lengthening and he's been growing. So I've now had to say, look, to the family, look, we must change them now. They've been in for too long, even though he's, developed really well and the rods have been lengthening a bit each time. But generally 3 years, 4 years, I change them.
Mm-hmm. So what's your experience when you are doing definitive surgery for such cases regarding the metal losses and the soft tissue status because the debris?
Yeah, so usually the metallosis is in the rod bed. So there's usually a capsule around the rod, a soft tissue capsule that is stained black from the metallosis. But it's not that the metallosis is everywhere. It's just in the bed of the rod. And so I tend to excise the capsule, excise it, send it for histology, irrigate it. And, and that's, and we haven't had any problems with it.
Even the infection rate is like, it's not high compared
to
non-magnetic. Okay.
No.
So we have question. Dr. Bassel can go ahead and ask your question. He asking about
Yes, Dr. Jabbar, can you hear me?
Yes.
My question is, there is any specific clinical conditions where the magnet may cause trouble to the patients?
Well, if you've got, so you have to take advice. So if you've got patients with neurological conditions where, the neurosurgeons want to follow them up with repeat MRI scans, that's a problem. Because, the magnets causes artifacts and you can't visualize the spinal cord. If you have children with pacemakers, if you have children with, these artificial or shunts with batteries, so all of those conditions, you have to discuss the risks and benefits, not just with the family, but also with your colleagues from other specialties about the possible risks.
Mm-hmm.
And is the problem in the rod itself or the remote control? Is the magnet present in the rod or in the remote control?
It's the magnets present in the rod, and it's the magnets present in the rod and possibly the remote controller when you're doing the lengthenings. So children, sorry?
Yes, my second question, what's your definition of failure? When you said this rod is failed and I need to change it to a different kind of treatment?
Yeah, so the most obvious failure is when the rod breaks. okay, or when screws pull out. In my mind, relative failure is failure to distract, okay? And the conundrum with failing to distract is, if there is a failure to distract and the curve is getting bigger because of that, then that to me is an indication to revise the rod. If there is a failure to distract, but the curve is under control, then in my mind, that is not an indication for an immediate revision. So in those sort of cases, I will watch them, I'll bring them back, I will repeat the x-rays. And if it gets to a point where I feel, well, look, to keep the rod in, not distracting, is causing, is likely to cause more complications, then I'll take it out.
Thank you very much.
Okay, yeah.
Is there any other question? Any other question? No questions. Or thank you very much, Dr.
Okay.
Colin. Really great presentation, and great to hear this from expert person.
Thank you very much.
Thank you very much, Colin.
Yeah, thanks, Abdul. And yeah, stay safe. Well, I don't need to tell you to stay safe because you don't have any cases. But no, thank you very much. Yeah.
Thank you very much, and enjoy your holiday.
Yeah,
Thanks.
you too. Thank you. Bye-bye. Bye-bye.
Everybody.
Bye.
Bye.
Bye.